Management of anterior base the tumors. Uh, the entire skull base has been divided into anterior, middle, and posterior, and the most common lesions that affect the anterior skull base either arise from either they arise from the brain side or from the olfactory epithelium in between, or from the nasal and the sinus sides. So practically this entire area has tumors which can arise from the intracranial cavity, the junction between the nose and the cranium, that is the cribriform region, and the paranasal sinus or the nasal cavity. Now, generally this has a common symptomatology, and all these lesions will have some common rhinonasal complaints, and they generally go to a ENT specialist. And on being a practice to do a plain scan, they find some soft tissue reported as polyps, and then they undergo a FAS, and the final report turns out to be malignancy, and then they are subjected to radiotherapy. So the problem is mainly the evaluation, a proper evaluation that needs to be done before the patient receives an inferior quality of the treatment or unplanned treatment. And then finally they are subjected to radiation, because now the margins cannot be revised, nor the tumor or can be resected further. So primarily this region of anterior skull base, the majority of the load or the tumor is shared by the tumors arising from the sinonasal cavity. That means the nasal cavity, the sinuses, like in order: maxillary, ethmoids, frontal, and the sphenoid. So these are a distinct group of tumors. Basically, they have, though they are very rare, or like 3% in entire head and neck cancer, but as compared to other head and neck cancers where squamous cell carcinoma predominates, this group of tumors, they have a wide variety in terms of histology, and squamous is just a part of it. So around 50% only are squamous, rest all other are non-squamous cancers. So this has a wide histological variety, and that makes this class of tumors are very distinct. Majority of these tumors, if we see from arising from ethmoids or maxillary, they are kind of infracranial or subcranial region, and very few of them involve dura, and they are generally node negative. So how do you kind of do a workup and proper evaluation or proper workup, so that you don't end up in unplanned strategy or an unplanned situation on the table? So most importantly, I think the history part gives you a very much clue about the pathology in a way. Unilateral nasal mass, single-sided nasal blockage of a recent or a little bit of 2 to 3 months of origin. Primarily important is a unilateral nasal mass. So this is a very important history that one needs to be very sure about it, or maybe take it very importantly. And evaluating this nasal mass of unilateral nasal blockage like anosmia, or a history of epistaxis, intermittent episodes of epistaxis, this all history points towards some lesion in the on the nasal side, and not only a deviated nasal septum or an allergic or an inflammatory polyp. The second most important thing is to do evaluation of the vision. If there is any headache, vision, diplopia, like epiphora, headaches. So these are other symptomatology that needs to be asked in a way to consider what could be the pathology that is affecting the patient. A detailed nasal endoscopic evaluation will guide for the overall evaluation of the nasal mass when we are doing so. So whenever you are kind of evaluating, so whenever you are trying to evaluate, unfortunately this video is not being seen here. I was able to play it again earlier. So important thing is, whenever you do a nasal endoscopy, you have to see for the nasal mass, the origin of the mass from the meatus, from the turbinates, from the septum, from the roof, where it is kind of originating it. Try to put your endoscope all around, and the suction tip to see if that lesion is attached or infiltrating the nasal septum, the turbinates, or the nasal floor. and go right up to the stalk or to the origin of this lesion, which will give you a clue of the possible etiology or the possible pathology that is this lesion could be. And this gives you a fair idea about the further management or the further workup that you need to plan. I'm sorry for the video which is not being played. So then important thing is biopsy. Now biopsy, preoperative biopsy gives you a very good impression about how further management will go, because in this group of tumors, the entire treatment plan depends on the histology that the patient is having, the histology of the tumor that the patient is having, and it has a very important pivotal role in the further management. So biopsy of the lesion, an adequate representative biopsy is very important in a routine hematological evaluation. HP or added superadded IHC may be required to rule out any other tumors which are not possible on routine HP. So then this, as I discussed, this group of tumors, they have a wide variety of histology, where you can say squamous cell carcinoma is just a part of it. You can have neuroblastoma arising from olfactory epithelium, adenoid cystic from the minor salivary gland, melanoma, mucosal melanomas from the nasal cavity, sinonasal undifferentiated carcinomas from the neuroectodermal tumor tissues, and other tumors like lymphoma, sarcomas are also arising from this region. And so this gives a wide spectrum of the tumors, and the histology is becomes a very important. This is the WHO classification of the variety of tumors that can happen in this sinonasal cavity. You can see the histological variation. When you come to the staging, so primarily if it is in the nasal cavity, maxillary sinus or ethmoid, so till the level it is remaining to the confining to its own origin site, it is considered as an early stage lesions. The moment it starts encroaching to the surrounding structures, one sinus going to the other sinus, or from one wall going beyond the confines of the walls, or entering the orbit or the intracranial component, makes the patient an advanced stage disease. So most important thing in management is to evaluate the true extent of the lesion and possible probability of the histological variety or the type of the lesion, and how do probably we go further. So CT scan, MRI and PET scan, these three imaging modalities are at times complementary to each other. For evaluation of sinonasal cancers, MRI precedes other investigation, and CT scan is always complementary for the bony evaluation. So a contrast MRI from skull base to root neck, primarily evaluating the morphology and the extent onto the soft tissues of the, so intradural extension or a transcranial extension, dural infiltration or a transdural disease are very well seen and picked up on MRI. CT scan helps to understand the bony limitations or the bony erosions and the bony demarcations of for the surgical planning. In conditions like when there are high grade tumors or more aggressive tumors, where the chances of like SNUCs, SNUC, where you can have a chance of distant metastasis, PET scan may be added to kind of stage the disease and plan the further management. In nutshell, treatment is surgery, radiation or chemotherapy. By and large, all these tumors are primarily surgery means as a major role, except few select group of tumors where chemoradiation or neoadjuvant chemotherapy precedes the definitive therapy. So histology determines the treatment, and low-grade tumors like well-differentiated adenocarcinomas, intestinal type, they are primarily managed by surgery alone. In terms of moderate intermediate group of tumors, you may add surgery and radiotherapy as an adjuvant therapy, but high-grade tumors, you have to add systemic therapy in a way or other to manage these tumors. So histology is a true determinant of the type of management that you will be planning. In general, treatment guidelines for anterior skull base tumors and primarily arising from the sinonasal cancer. So surgery alone may be for low grade tumors. So this is one set of tumor or category of tumor where histology determines and defines your treatment guideline. So for all low-grade tumors like adenocarcinomas, low-grade adenocarcinomas, low-grade sarcomas, low-stage squamous cell carcinomas, basal cell carcinoma, chondrosarcomas, they are managed surgery alone. But with little bit advanced cases or high-grade tumors like esthesioneuroblastoma, Kaddish C, or adenocarcinomas, adenocystic carcinomas, squamous cell carcinomas, they are managed with surgery and radiotherapy. There are a few set of select group of patients histologies where you have to use induction chemotherapy in the initial treatment, and those are high grade sarcomas, high grade or high stage squamous cell carcinomas where there are perin invasion, like incidence of possibilities of orbital invasion, or it is going through transcranially into the cranial cavity, SNUC and other neuroectodermal cancers, or mucosal melanomas. They are the set of tumors where you would like to use NSCT induction chemotherapy in the initial phase to have its benefit. We'll discuss that in the next slides. Certain group of patients like lymphoma, avic sarcoma, or most rhabdomyosarcomas. So sarcomas and lymphomas are primarily managed by chemoradiation. And certain where multimodal therapy are needed are squamous cell carcinomas, adenocystic carcinomas, and high-grade sarcomas. Now, of surgical options, you have open surgical options versus endoscopic or endonasal approaches. So, open approaches like transcranial approaches, where the skull-based tumors are primarily involving the cranial side. You would do open surgical approaches where you will have a variety of modification, frontal, bifrontal craniotomy, where do craniotomy is bifrontal, terional, fronto, temporal, orbitozygomatic, or transbasal craniotomies, wherein the tumors are more on the cranial side. You need to open up brain, and here the major concerns are the direct problems of the brain retraction and damage to the optic apparatus with a significant blood bone loss. Transfacial approaches are more for the subcranial disease. So when the disease is limited to below the cubits or the level of nasocranial separation, those where you will be doing a transfacial approaches like medial maxillectomies or lateral rhinotomy and approaching medial maxillectomy like this. So here the tumors are basically subcranial. They are either involving the maxillary sinus, ethmoid sinus, or on the palatal side or infratemporal fossas, where you will do open approach by a transfacial approach. Different approaches like lateral rhinotomy, Weber-Ferguson, Lynch extension, Deffenbach, mid-facial degloving, or with using Leefort osteotomy to access to the higher positions. The benefit is it's a direct approach and you can do an en bloc resection, but the problems are it leaves behind a facial scar. At the same time, the deeper margins are blind. You cannot take a controlled deeper margin and then you tend to develop get positive margins on the deeper aspect. Certain times when the tumor has both the components, where it is an intracranial as well as intracranial extension, you have to combine both these approaches, and that is known as craniofacial approaches. And these are basically where the tumors are extending into the intracranial space, paranasal sinus, orbits, palate, maxillary sinus, infratemporal fossa. So where the extensive tumor with both intra and extracranial extension, you have to combine all these facial, transfacial, and the transcranial approaches in a combination. And a set of patients where majority of the tumors are subcranial, you can do an endonasal approach, wherein the entire tumor is managed endoscopically, and there is a piecemeal removal of this tumor. However, the major concern in this skull-based tumor or surgeries are whether an en bloc resection is equally is important, or a piecemeal resection is equally effective. So various data have evaluated the outcomes of en bloc as well as piecemeal resection. So most important thing is the outcome, or the local regional control doesn't change. What is important is that you get a negative margin at the base, and that is very well possible using an endoscopic approach also. So piecemeal resection doesn't change or alter the course of the local control. The only concern is it needs a proper expertise in and training, as well as the proper infrastructure to manage the disease. So open versus endonasal, there was a large national cancer database study and of involving 2000 plus patients, wherein they saw they kind of compared the results between the two. The overall 5-year survival rates were equivalent to both, and en bloc versus piecemeal had no significant difference in the outcomes. The only true predictor was a negative margin. Now, endonasal approach is basically all the lesions which are either confined to the sinuses, not involving the external skin, not involving going or involving the palate, or going beyond the mute pupillary lines on either side. They are all amenable to endoscopic or endonasal approach. Now, a transcranial disease limiting up itself to the dura and not going more transdurally or involvement of the brain, transdural extension, they are still amenable to endoscopic approach. You can do an endo CFR, that is through the nasal cavity. You do I'm sorry, you can do a craniofacial resection of the anterior cranial fossa, and the entire dural resection is also possible. With the margins can be taken on the dura till the level of the plenum. I mean, the posterior extension is very important, how much posterior extension of the disease is. So if it is going beyond the cribriform plate, the possibility of converting into open is more. So the dural repair, it becomes difficult if it is going more posteriorly beyond the cribriform area. And so endoc CFR is also feasible if there is an anterior involvement of the dural involvement. So when you are planning for maxillectomies, these are the different types of maxillectomies: medial, infrastructure, suprastructure, subtotal, or total. Medial maxillectomies are possible endoscopically, while other these things are to be done open. Radiotherapy as a definitive therapy has a very limited role, especially only for those locally advanced unfit patients for surgery. Otherwise, they are primarily as an adjuvant role in advanced stage tumors, high grade tumors, high risk histological, perineural or lymphovascular involvement, presence, lymph nodes, positive margins, or any other concerns where there is a chance that the surgery adequacy is doubtful. It can be 3D CRT, IMRT, or a recent version is a recent addition is a proton therapy. Now, IMRT is by and large preferred for majority in view of the more of focused and planned radiotherapy, and the chances of the limitations that we have in skull base are the orbits on either side, the brain, cranium, the the carotids, which can be better spared with IMRT as compared to 3D CRT. Protons, they benefit because they can deliver a larger dose to a tumor site and sparing the normal structures, preventing cost complications. But however, there are still limited options in terms of availability of the centers. So by and large, IMRT as of now stays a major mode of radiotherapy. Systemic therapy is generally as a part of multimodal therapy. Neoadjuvant chemotherapy is primarily to optimize the tumor biology. Basically, it helps to optimize drug delivery through an intact tumor blood supply. So it's thought like if there is entire intact vasculature, the drug will be reaching more in a concentration, and that will be effective to sterilize the downsize the tumor. But the problems are it delays the loco-regional treatment. Concurrent settings are generally limited role, and in adjuvant setting it acts as a radiosensitizer, but not very promising in this thing. Now, NSCT has the concise, or maybe the thought behind giving NSCT in anti-scalp tumor is to improve the local tumor control rate, so margin sterilization for orbit preservation. If there is a transcranial extension or transdural, to kind of downsize or shrink the tumor. For high-grade tumors, in view of its distant metastasis and aggressive behavior, to control the tumor growth, and also for bioselection. These are various data or studies that have been focused on induction chemotherapy in head and neck in the sinonasal cancers, wherein primarily it has been used for squamous cell carcinomas, in some cases as adenocarcinomas, olfactory neuroblastomas like Cadiz C or D, sarcomas, melanoma, and SNEC. So these are the select group of histology where NSAT becomes as an initial treatment plan, which helps us to kind of downstage the disease and plan for definitive therapy later on. At the same time, helps us to bioselect the disease whether these tumors are going to be responsive or having further outcomes. So in order to finally take home message, SNEs are a distinct variety of tumors, wide histological variation. The treatment depends primarily on the histological type. Surgery has still the primary role, but in certain group of patients, chemo-RT like lymphomas and sarcomas, Ewing sarcoma, chemoradiation are the primary modality. NSAT has a role in select group of high grade malignancies. Radiation is adjuvant or concurrent for select group of patients, and systemic therapy has a limited role.
Hello.
Yeah.
Thank you, sir. Thank you for such a comprehensive presentation on this topic. It was very informative for all of us and very well and very short and crisp. Thank you so much for this presentation, sir.
Thank you.
Now we'll be moving towards the case presentation. For case presentation, I'll be inviting Dr. Deepa Nair, Professor Head and Neck Oncology at Tata Memorial Hospital, Mumbai. Ma'am, are you there?
Yeah, I'm here, Ravi.
Yeah, okay. Dr. Kapil Sikka, he is Additional Professor, Department of ENT, AIMS, Delhi.
Good evening, everyone.
Good evening, sir. Then Dr. Rahul Naga, he is Professor and Specialist ENT and Endoscopic Sinus and Skull Base Surgery at INHS Ashwini, Mumbai. Sir, are you there? I think he is not online yet. Dr. Pankhuri Mittal, she is Assistant Professor ENT and Head and Neck Surgery at AIMS, Gorakhpur.
Hello, everyone.
And then Dr. Siddharth Shah, again, Head and Neck Oncosurgeon, Endoscopic and Robotic Surgery, Zydus Cancer Center, Ahmedabad. For case presentation, I'll be inviting Dr. Kiran Joshi. She is MCH resident at Amrita Hospital, Mumbai. Amrita Hospital, Kochi. Dr. Kiran?
Yeah.
So I think we can start with the case presentation now.
Is my screen visible?
Yeah, it is visible. It is visible.
Good evening, all. I am presenting a case of 61-year-old gentleman, resident of Muscat, shopkeeper by occupation, presented to us with chief complaint of right nasal blockage for past 3 months, history of epistaxis from right nasal cavity for past 2 weeks, and history of mild bulge over right side of dorsum of nose for 2 weeks. Coming to present history, according to patient gives the history of right side nasal blockage for past 3 months. When he presented, he was apparently asymptomatic 3 months back when he developed right side of nasal blockage, which was insidious in onset and progressive in nature. Now now there is complete obstruction. It is not relieved by medicines. No specific aggravating factor is there, and it is associated with right side of facial heaviness. Patient also gives complaints of epistaxis, 3 to 4 episodes till now. Spontaneous bleeding is there, which stops on local pressure. The amount is mild, 3 to 4 drops at a time. There is no aggravating and relieving factor for the same.
So sorry to interrupt here. Can I have the age again?
61-year-old. Patient also gives history of bulge over the right side dorsum of nose, which is insidious in onset, gradually progresses to current size.
Do we have a clinical photograph here?
Unfortunately, I have lost the photos and the endoscopy. I have the MRI only.
So you have only MRI. So can I ask a question here? What is the clinical relevance of age if the patient is coming at this age vis-a-vis if they are coming at much younger age, maybe in childhood?
So if patient is coming at advanced age, then the history point towards the tumor malignancy. And if the patient is presenting at young age, then there could be polyps, allergic polyps.
So So can you put your symptom slide again, please? Let me make a point very clear. You have said that there is a nasal blockage. You have said there is epistaxis, and you have said there is a bulge over right dorsum of nose. That's why I was very interested in having a clinical photograph here. And your first differential at younger age is nasal polyp. May I disagree with that?
Sorry, sir, I couldn't hear you.
You said that there is nasal blockage, there is epistaxis and bulge over dorsum of nose. And your first differential in younger age is polyp.
Infected polyp could be there, or angiofibroma.
I would suggest that we can categorize the age according to very young, that is pediatric population, maybe less than 5 years, 7 years of age. Then there can be teenagers, then there can be young adults, and then there can be elderly population. And differential diagnosis would be slightly different in those subcategorization of ages.
Any known medical history, comorbidities or something?
Yes, sir. That is in next slides. Patient is diabetic and hypertensive. Patient has also decreased smell perception. History
What
of
is the relevance of dental extraction here? You have categorically put there is no history of dental extraction.
yes, sir. At this age, patient could have loose tooth for which dental extraction for that patient could have gone to dental extraction.
What is the relevance in your case?
In my case, if there is malignancy which is involving the floor of maxillary sinus, patient can have loose tooth.
Okay.
So rather it should be a spontaneous fall of the teeth rather than an extraction. Spontaneous loss of the teeth. That should be a proper history. Extraction probably doesn't give you a clue that the patient has some malignancy underlying.
And the perspective is both ways. One, the malignancies or tumors, they can lead to loosening of teeth, for which the patient might consult a dentist. And otherwise also, if the patient has had a dental extraction or any dental procedure, those can lead to some paranasal sinus pathologies, which can manifest in a similar manner. For example, sinusitis. In fact, there are some hypotheses that fungal infections are also commoner in patients who have had some dental fillings or dental procedure.
There is no loss of sensation of cheek, no history of nasal discharge, post-nasal discharge or sneezing, no history of loosening of teeth or dental infection, no history of snoring, mouth breathing, no history of fever, no history of trauma, no history of restricted mouth opening, no history of protrusion of eyes, no history of vision disturbance or diplopia, no history of ulcer over cheek or palate. There is no history of neck swelling, no history of ear complaints, and no history of voice change.
What's the relevance of restricted mouth opening here?
If the tumor is involving infratemporal fossa involving the pterygoids muscle, then patient can have trismus. Or if there is a pain, that could also patient can also have restricted mouth opening.
And what about voice change, breathing difficulty?
So if the tumor is filling the nasopharynx choana, then patient can present as rhinolalia clausa. Patient can have, coming to past history, patient is a diabetic and hypertensive on regular medications. Personal history, consumes mixed diet, normal bladder bowel habit, no history of tobacco or alcohol use. Family history is insignificant. To summarize my history, 61-year-old, shopkeeper by profession, diabetic and hypertensive gentleman, presented with right side of nasal obstruction, right side epistaxis on and off, with mild bulge on right side of dorsum without any history of smoking and alcohol.
Can you go back to the occupation history? So any particular occupation which could be relevant to the present complaint?
So in paranasal sinus, the occupation is very important. In 40% of cases, it is associated with sinonasal malignancy. So if there is wood exposure, soft wood, it has relation with the squamous cell carcinoma. 70 times more squamous cell carcinoma develops in softwood exposure. Adenocarcinoma develops in hardwood exposure. Similarly, nickel has relation with the squamous cell carcinoma, chromium, leather, and polycyclic aromatic hydrocarbons, radium, brass, these all are related with development of malignancies.
So presently, this patient doesn't have any occupational incidents. Neither he is a tobacco user.
Kiran, Deepa here. Is there any association of tobacco and paranasal sinus malignancies?
Yes, ma'am. So there is a case control study published in 1987 by Haynes. In his paper, he said that there is a relative risk of 3.01 with a significant hazard.
What's the
That is for,
yeah. Yes, ma'am.
sorry, what tobacco usage was in that study?
Ma'am, case control study published in 1987 by Haynes, Hayne.
No, all tobacco smoke.
Smokers. All smokers developed stomach.
Was the association of snuff or snooze with paranasal sinus cancers?
I have not read the article completely. I have read the abstract only, but yes, in snuff, because the snuff particle that get implemented into the septum and the middle turbinate, it can the patient can develop.
Can it be viral also?
Sorry, sir.
Can it be viral also?
Viral also, yes, sir. HPV related in 2017. Bishop article has published new WHO classification of tumor where HPV multiphenotypic sinonasal carcinoma is associated with HPV. Not midline carcinoma has association with EBV viral. These are.
Can you tell approximate incidence? Maybe if we put at oropharyngeal at around 20%.
So it is in the range of 5 to 7%, less than 5%.
I would put it at 5 to 6%. Right?
Coming to general examination, the patient during the examination, the patient was conscious oriented, moderately built and nourished, KPS 80, pulse 78 per minute regular, blood pressure 124 by 80 mmHg in right arm, respiratory rate 18 per minute regular, no use of accessory muscle of respiration, no pallor icterus clubbing cyanosis, generalized lymphadenopathy. Systemic examinations are normal. Coming to local examination, on inspection, the external contour is symmetric with a small bulge 1 into 1 centimeter noted in right side of dorsum of nose. The overlying skin was normal and pinchable. There was no scar, sinus, ulcer, and fistula. The root of the nose, supratip, tip, alae, columella, nasolabial groove, nasomaxillary groove appears normal on inspection.
Was the bulge in predominantly cartilaginous dorsum or was it in the bony dorsum?
Sir, it was in the bony dorsum.
High up?
Yes, sir, high up. It was coming till the junction of bony and cartilaginous. On inspection of vestibule, there is a polypoidal mass seen in right nasal vestibule. Left vestibule was normal. Septum, cartilaginous septum was deviated towards the left side. On palpation, the inspectory findings were confirmed. 1 into 1 centimeter firm bulge is noted on right side of dorsum with normal overlying skin. Vestibule polypoidal soft mass seen filling right nasal vestibule. Could probe all around the lesion, not sensitive to touch. Septum, the cartilaginous septum was deviated towards the left side. There was no raised temperature, tenderness, and fluctuation over the swelling over the bulge. No paranasal sinus tenderness was present.
So lesion was insensitive to touch.
Yes.
So what does that indicate?
So if it is a inferior turbinate or the nasal mucosal lining, then it will be sensitive to touch. If the mass is, if there is a mass, then that is insensitive to touch.
For paranasal sinus cancers, they are not sensitive to touch. Let me put it: if it's an inverted papilloma from one part of nasal cavity, it's hanging in the nose. Will it be insensitive to touch?
If it is arising from the lateral wall of the nose, then patient can have pain. But if it is freely lying in the nasal cavity, then patient.
Masses will have to arise from somewhere. They can't be just freely lying in the nasal cavity. That won't be called as mass. I would not agree with that point. So you have said cartilaginous septum is deviated to one side. Do you think that it was deviated because of mass or was it a previous deviation?
Because Patient has not complained of nasal obstruction from the early childhood. So maybe this deviation is because of the mass.
So it may be because of mass. Could you see the other side nose?
No, sir. I could not able
So it
to.
was severe enough that it was almost occluding the other side.
It was obstructing the other side also. I could not pass my endoscopy.
Go on.
Patency test, the cold spatula test decreased fogging on the right side. Cotton wool test, decreased movement on the right side was present. Oral cavity, no palatal or upper gingivobuccal sulcus bulge is present. No loosening of teeth is present. Eye examination, bilateral extraocular muscle movements are full and free. Bilateral visual acuity normal. No ptosis, proptosis or diplopia. In neck, there is no palpable lymphadenopathy. Cranial nerve examination, olfactory nerve, there was decreased smell perception, but the rest of the cranial nerve examination were normal.
Did you test the fields of vision? And do you think they're relevant?
Yes. Opthal evaluation was done. So they have checked the field of vision, but I have checked only the visual acuity and extraocular movements.
If you are told to give a rough estimate of field of vision, are you able to perform that? If I want to know whether it's decreased or not.
Field of vision, sir, I don't think.
How did you see the optic nerve?
Sir, optic nerve, we can do the testing of the pupillary light reflex.
So pupillary right reflex is a test for optic nerve function.
It is only because it forms only the afferent pathway, so not exactly, but we can check the visual acuity.
What is RAPD?
So RAPD, we can see the pupillary dilatation. That is because of the pupillary reflex. Then there is
It's an oversimplified answer, I would say.
if there is a afferent pathway defect of pupillary reflex, that the pupil will be dilated.
So if left optic nerve is involved,
Yes.
suppose the patient is here is normal, but suppose patient is has early optic nerve involvement, is partly blinded. What will happen to RAPD?
So on that side, because the efferent is normal, the fifth nerve is normal. So the
Just tell me, when you shine light on right eye, what will happen?
opposite side, there will be the there will not be the constriction.
I feel your concept is all right. What you're telling is all right, but the way you are conducting it, I think you need to read it, because briefly putting, you have to put the flash of light on both eyes one by one, and if the efferent pathway of ipsilateral side is affected, then while you shine the light on other side, the pupil will not stay constricted; it will dilate. So that is RAPD, to be precise. So how do you check the motor and sensory trigeminal nerves?
So for sensory, we have the light, touch and pain. We can ask the patient to close the eye, and then with the cotton wool, we can test the light, touch. And
So you told the patient to close the eye.
Close the eye, then on one side we can compare with the other side for the light touch with the cotton or wool.
Why not open eye?
Then patient can be quiet.
So where did you touch on closed eye?
So for trigeminal nerve, we check on the cheek, V1, V2, V3 territory area. Over the forehead, we can compare both the sides. We can compare the cheek either side, and similarly.
You can test the trigeminal nerve with eyes open, because cornea is a very sensitive part with for your cotton based test for trigeminal nerve. But you need to do it properly so that patient is not biased. And motor?
And for motor, we can ask the patient to clench the teeth, and we can feel the tightness of the masseter and temporalis. Simultaneously, we can see the jaw jerk by hammering over the lower jaw, and we can see the deviation of the jaw.
Okay, great.
Coming to nasal endoscopy, septum was deviated to left side, could not negotiate beyond the deviation. Anterior.
Kiran, would your cranial nerve examination be complete?
No, I have not examined all the cranial, because for this case I thought rest of the cranial nerves.
So would not theoretically a nasopharyngeal mass or a nasal mass go laterally or posteriorly to involve the jugular foramen also? So always complete the entire cranial nerve examination, please.
How do you check the ninth nerve?
For ninth, now we can check the gag reflex. Shall I tell all the cranial nerve examination or proceed further?
If you have done.
Sir, nasal endoscopy, I'm sorry, I've lost the video. Septum was deviated towards the left side, could not negotiate beyond the deviation. Anterior nasal floor was normal. Anterior 1/3 of inferior turbinate on left side was normal. Polypoidal mass was seen in the right side of nasal vestibule.
What is polypoidal and what is non-polypoidal?
Sir, polypoidal when there are multiple lobulations are there, and non-polypoidal it could be a single mass we can see.
So this was a multi-lobulated looking mass.
Yes.
So I would like to have some more description on what the mass looked like. Was it pink? Was it red? Was it pale? Was it gray? Was it slough covered? Where did it seem to arise from?
Yes, sir. So there was mild discharge was purulent, not purulent. There was whitish discharge present on the floor of the right side of the nasal cavity, which I suctioned out. And the mass was not very bright red, but it was pink in appearance.
You touched the mass? You tried to suck that discharge?
Yes, sir.
Did it bleed?
No, sir. Shall I show the MRI pictures?
What is your diagnosis?
So, considering the age,
Can you summarize the things again? You put a summary after your history. Can you summarize things again?
61-year-old male, shopkeeper by occupation, diabetic, hypertensive, presented with a right side of nasal obstruction, epistaxis, and bulge on the right side of dorsum. On examination with the polypoidal mass in the right side of the nasal cavity.
What's the duration?
For past 3 months. So
it's a bleeding mass.
Yes.
Only one-sided in a 61-year-old, and it's progressing rapidly, more or less static.
So gradually progress.
3 months has caused a bulge, has caused a septal deviation significant enough to obstruct the other nose. I would call it more or less rapid only. So what comes to your mind?
So it could be sinonasal malignancy. It could be inverted papilloma, though the history of papilloma requires long history.
Long history in the sense 5 years?
2-3 years. So
you have been very in a catchy manner repeatedly saying is a diabetic. Can it be fungus?
Fungus, patient has no other symptom except the nasal. If there is a fungus in a diabetic patient, then it could be invasive. Patient can present with orbital symptoms also. It can be fungus.
There is protrusion of eye, or you said there is nothing?
No orbital symptom.
And you said it can be polyp in a young patient. Can it be polyp here also?
So if the patient was having polyp, then there should be a history of discharge, which was not there. Patient can, in polyp, patients can initially present with the sinusitis kind of features, but patient didn't give such kind of history.
Kiran, so would it be safe to say that at the end of your history and examination, you just have a right nasal mass which you would want to evaluate further? I think you should go with that rather than try and offer a histopathological differentiation.
Yes.
Go ahead. How will you manage this case?
First, I would like to do the imaging in terms of MRI nose and PNS with contrast enhancement with thin but high resolution CT PNS. By doing the imaging, I would be able to know the vascularity of the tumor for taking the biopsy in OPD basis or in under GA. So after getting the imaging, I would like to proceed with the biopsy to know the mass.
Kiran, to stop you here, why would you want to do an MRI as your first investigation? Why not just a CT-PNS? Because a CT will give you most of this evaluation, including vascularity, extent of disease. And like Kapil said, if it is a fungal, that itself could be picked up on a CT scan. So if your initial differential can be done with your CT scan, so why do you want to do an MR as a first investigation? Hello. Yeah.
We can go ahead with the contrast enhanced CT scan of paranasal sinus, and then later on we can get the, if required, then we can get the MRI.
So what are you looking for in your MRI other than the vascularity and for biopsy? Any particular things you want to look out for in the MRI as a clinician surgeon?
MRI, we can know the soft tissue extension of the tumor, if there is a perineural invasion, orbit involvement, or anterior skull base involvement, that all we can see the MRI. And to differentiate in a CT scan, we can't differentiate the secretions with the tumor, so that we can also can differentiate with the MRI.
There are certain things. I think we have dual uh, aim or objective here. One, we have to have a rough differential diagnosis in mind, and two, we have to evaluate the extent of disease. So there are certain features that are very typical on CT scan, like focal hyperostosis in inverted papillomas. There are characteristic dural enhancements in MRI for meningiomas, orbital tumors. There are certain, for example, fungal sinusitis, as ma'am said, that they are more characteristic on CT scan rather than MRI scan. So what we want to explore is, should it be both? Because you have put MRI first. I'll do MRI first and also couple it with CT scan.
So MRI is a complementary to CT scan. If we are going for surgery, then we would like to know about the skull base involvement, orbit involvement, the extent of the lesion, and if there is perineural invasion like in adenoid cystic carcinoma, which we can misinterpret by CT scan. So it is a complementary.
Okay. So you will do both.
Yes, sir.
In all nasal masses, you will do both.
Not in all nasal masses. If you are proceeding for the surgery, yeah. In those cases, of course, we would like to do the both.
If you're not doing surgery, you don't do MRI or you don't do CT.
So CT scan is required. At least CT scan, because we have to, for biopsy, we have to know, we should know the
Biopsy is a surgery or not?
biopsy.
Is also a minor surgery, you can say. You said biopsy under general anesthesia.
So if it is a vascular mass, which is a bleeding,
So what tells you that?
So there will be contrast enhancement in the gadolinium MRI. So by seeing that, we can see that. And in CT scan, if it is enhancing, then it could be vascular mass. So like hemangioma, hemangioendothelioma, hemangioparasitoma, then probably we can take precautions. We can do in general anesthesia also.
But generally at your place, you do it under local.
Yes.
Can you name a few vascular nasal masses? You named one or two, but
AV malformation, hemangioma, hemangioparasitoma, esthesioneuroblastoma, not very vascular, but yes, vascular. In adult, angiofibroma in young, but we won't proceed for the biopsy.
Kiran, are there some tumors, malignancies, in which the CT will have findings which will surpass the MRI, which the CT is more necessary for diagnosis compared to an MRI?
Yes, ma'am. So if there is chondrosarcoma, where we can see the ring and arch-like ossification pattern, CT is diagnostic. And if it is a osteosarcoma, though it is rare in maxilla as compared to mandible, and in inverted papilloma, we can see the focal hyperostosis. So these malignancy.
Can you see malignant transformation of inverted papilloma on MRI?
So in CT scan, we can see the malignant transformation. In MRI, there will be the cerebriform pattern, but in CT scan, we can see the malignant transformation.
What are the causes of proptosis here? If you said there is no eye protrusion, if the patient has eye protrusion, what are the common causes that come to your mind, and what is better investigation in such cases?
So if patient is having proptosis, then it indicates that there is some retrobulbar mass. Paranasal sinus malignancy is coming through the inferior orbital fissure and pushing the eye forward. Or there is a retrobulbar mass in the behind the orbital apex, pushing the eye forward.
So one, you said it can be a bulbar extension, that is direct orbital extension. It can be retrobulbar extension, but don't forget one of the common factors that superradiate infections or tumors can also cause cavernous sinus thrombosis and cavernous sinus involvement, which in turn can lead to some degree of proptosis, one side or the other. Sorry, Pankudi, I think I interrupted you.
No, so I was just saying that loss of cerebriform pattern can suggest transformation of inverted papilloma on MRI.
Sorry, ma'am, I could not get you.
I was just saying that if there is the loss of cerebriform pattern, if there is loss of cerebriform pattern on MRI, it can also suggest malignant transformation.
In CT scan, where focus of hyperostosis, and there we can see where is the sclerosis. There we can see the malignant transformation. In MRI, we get the cerebriform pattern indicate this is inverted papilloma. So we can correlate with that thing.
So Kiran, I differ with you. The hyperostosis and the sclerosis will suggest that it is a long-standing tumor. Because when you have erosions, that suggests it's malignant. Hyperostosis is more where the tumor is long-standing. And I agree with Dr. Pankudi that loss of cerebriform pattern is in the areas where you have loss of cerebriform pattern, you suspect a SCC and you should try and target a biopsy from there.
Okay.
Can you differentiate between the dural inflammation and dural involvement?
Inflammation and dural involvement. So when there is a dural involvement, we can see the nodularity, and if it is more than 5 mm dural nodularity, then we suspect that dura is involved. If there is intraaxial intradural involvement, then we can see the edema inside the parenchyma. And if there is only extraaxial intradural involvement, then the edema, brain edema won't be there, parenchymal edema won't be there, just the dural thickening, nodular thickening more than 5 mm. And in inflammation on T2, it will be bright, hyperintense, but on contrast, there will be no enhancement. But when there will be dural involvement, there will be T2 hyperintense, and contrast, it will enhance.
Kiran, can you tell how and when we will plan our imaging based on the involvement for the dural involvement? What imaging will you do for whether a CT scan or an MRI for such a case?
Sorry, sir, I couldn't get you. Can you repeat once again?
Yeah, what investigation? Suppose you have done a CT scan, you see a dural enhancement. Will you do an MRI to confirm what is the amount of dural involvement or the orbital involvement? How will you make a decision for these two places?
For decision for the surgery or decision
for decision for the further management. Suppose you are going to give NACT, when you are going to give NACT with the imaging, so, or you are going to add on an imaging. When will you do a CT scan only, and when will you add on an MRI on these investigations?
So on first imaging is CT scan. If on CT scan there is involvement of orbit, dura, then we will get the MRI scan to see how much the dura is involved, how much is the orbit is involved, because the further surgery will be decided by the involvement of the orbit and dura. And if there is just abutment of the lamina or just abutment of the dura, we can go ahead with the surgery. But if there is periorbital involvement breaching the orbita, we can give neoadjuvant chemotherapy. So there are three meta-analysis by MD Anderson group, Bossi et al., Ahmed et al., and Gautam et al., giving the NACT neoadjuvant chemotherapy in SNEC, SNAC, and esthesioneuroblastoma, where they have seen the better outcome by giving the neoadjuvant chemotherapy. And there we have one paper from University of Virginia in esthesioneuroblastoma, where in 34 patients over a 20-year period, they have given the pre-op CT chemotherapy. Pre-op chemotherapy in Kaddish C and pre-op radiation in Kaddish A. There they have also seen that 2/3 of reduction of the tumor size they have noted. So NACT for organ preservation, like orbit preservation, when it is reaching the periorbita, and in squamous cell carcinoma, there is dural involvement, intradural, intraaxial involvement, then we can give NACT, though there is no RCT on this.
Kiran, for the benefit of the students, do you know of any orbital grading, grading of orbital involvement?
There is a Iannetti et al. Grading of orbit involvement. In grade 1, in grade A, there is only bone breach. In grade B, there is extraconal orbit involvement. And in grade C, there is muscle intraconal involvement of the orbit, muscles, periorbita, and globe. So based on that, orbital exentration is decided. If it is grade C, then we have to go ahead with the orbital exentration. In grade B, there is plus and minus option of orbital exentration.
So if you're not planning orbital exentation, how are you treating the orbit?
If there is involvement of orbit and I'm not planning, I couldn't get you, sir. Can you?
So if there is a minimal orbital involvement or the tumor shrinks as a result of NACT intervention, still do you treat the orbit or do you leave it?
So if it is only the lamina, abutting lamina is involved, then I will resect the lamina and will send the periorbit as frozen. And when it is involving the muscle, of course, I would like to go with orbital exentration.
Will you radiate the orbit?
If we are radiating the orbit, then it is better to remove the orbit, because optic nerve can't withstand more than 45 grays. And if we are giving less than 45 grays, then anyhow the tumor in the orbit we won't be able to treat.
Very controversial statement you have made, Kiran. Yeah. So then most cases where there is tumor abutting the lamina papyracea, which will require radiation, you would suggest that we should do an orbital exentration?
You are saying wherever you need to radiate the orbit, exentration is better.
No, sir. If it is involvement of muscle, then I would like to go with the orbital exentration. If it is abutting the lamina papyracea, then we can go ahead with the surgery, sending the periorbita as frozen. There is no need of exentration of the orbit. If it is unresectable tumor, then we can send the patient for radiation.
We will give for a patient who has ethmoidal cancer, which you have resected the lamina papyracea, removed the periorbita, sampled the periorbitary fat and said that that orbital fat is negative. So preserve the globe. Is there,
Uh, So if the periorbita is negative, then we can limit our radiation to the medial wall only. There is no need to radiate the whole orbit.
So the radiation oncologist will always go by the pre-treatment extent of disease. So the orbital fat would receive amount of radiation. They will try and tailor the dose at the optic chiasm, but the disease in the ipsilateral orbit will be tailored, and obviously they're going to give IMRT in this. So the dose painting will be done to involve all pre-surgery tumor extensions, but they'll try and limit the dose at the optic chiasm. Okay. Can you proceed with your case?
Yes, ma'am. I will share the MRI scans.
Yes, please.
Stop sharing. Give me a moment. I'm sharing. So these are the axial. Ma'am, my screen is visible. Scans are visible.
Yes, scans are visible.
So this is an axial contrast enhances scan of the head and neck region. Coming from superior to inferior, we can see the superior sagittal sinus and starting of the frontal bone. These are the lateral ventricle we can see. Going downward, we can see some cystic collection, some multiloculated cyst sits in both side of the frontal sinus, lateral ventricle, and now we can see the appearance of the orbit. This is the frontoethmoidal recess coming on the left side. This non-enhancing multiloculated cyst just abutting the nasal bone anteriorly, extending towards the ethmoid sinus, abutting the lamina on the right side.
How do you know it's non-enhancing and it's not a central necrosis?
Because sir, this is the contrast enhanced scan, and I can see the low intensity in the center, and the periphery is comparatively bright. As such, it is not enhancing, the whole structure is not enhancing. So in the center, there could be necrosis, there could be fluid, which I will confirm on T2. So this multiloculated cystic lesion is involving the whole ethmoid gallery, abutting the right side of the lamina and left side lamina also, anteriorly nasal bone. Extending posteriorly, these are the optic nerves. We can see the optic chiasm, which is away. It is abutting the lamina papyracea in the whole extent and causing contour bulging on either side. We can see that
Can you comment on medial rectus muscle?
Yes, sir. So it is abutting the lamina and the muscles. There is contour bulging.
Can you see the lamina here?
Sir, lamina, actually, this is MRI, so I can't appreciate much, but it is because causing the contour bulging of the medial rectus on either side. So I can say there is abutment of the lamina on either side.
Might be erosion also.
Could be erosion. For that, I would like to bony erosion I can see on CT scan. Involvement of orbit I would like to confirm on T1. images.
These are T1 images.
These are contrast enhanced images.
So what is your conclusion? Is the orbit involved or it's not involved?
I can't comment on this because fat is suppressed, so I can't see the fat here, sir. So the periorbita fat is black.
Okay.
So this is the fat suppressed image, so I can't comment on whether the orbit is invaded or not. But definitely it is abutting the lamina papyracea on either side. That's why it is causing the contour bulging of the medial rectus muscle on either side. But it is not pressing the optic chiasm. Optic chiasm is free. How to go press this button? It is not going down. It is not going down. Just give a moment, sir. It is not going actually down. आगे वो करके so sorry for the interruption. So it is this is the orbit on either side. This is the sphenoid sinus, sphenoethmoidal recess. This is the septum. We can see the black line causing left side of the DNS. Now we can see the appearance of the maxillary sinus on the left side. Here on the right side, there is in medial wall is it is abutting the medial wall of the right side of the maxilla, and in left side also, and then it is involving the posterior wall of the right side of the maxilla, and this one cystic bulge is there in the maxilla, which is from the posterior wall. It is involving the pterygopalatine fossa here. These and in the sphenoid we can see the extension of this tumor also.
Can you show us the carotids and if the dura is involved or not?
Okay. So this is the clival carotid on either side, which is becoming the petrous carotid, the horizontal one. And this is the lacerum carotid on either side. And here the carotid is on the nasopharynx. So the carotids are well away from the lesion. So the lesion is involving the whole of the nasal cavity, which is not enhancing, multiloculated, involving bilateral nasal cavity, maxilla on the right side, involving the medial wall of the maxilla, posterior wall of the maxilla, infratemporal fossa, pterygopalatine fossa on the right side. And going downward, it is occupying the nasopharynx also. This large cystic space.
Do we have CT images also?
Sir, I have the T1 CT images are not there. T1 images I have. T2 images I have. So coming from top to bottom, T2 weighted axial images. We can see the T2 bright multiloculated cyst on frontal occupying the bilateral frontal sinuses. And this mass is well encapsulated causing abutting the lamina on either side. It is abutting the medial wall of the orbit on either side, causing deviation of septum towards the left side, multiloculated T2 bright mass with involvement of medial wall of maxilla, posterior wall of the maxilla, and on the right side of the infratemporal fossa, abutting the lateral pterygoid muscle on the right side. On left side, it is abutting the medial wall of the maxilla, causing contour bulging. And there is a large mass occupying the nasopharynx. The oropharynx and oral cavity rest is normal.
Do you have a sagittal sequence?
Yes, ma'am. So these are the sagittal images going from left to right. This is the cystic mass which is occupying the maxillary, maybe abutting or occupying, we can't say here, but there is no breach of inferior orbital fissure and pushing the orbit up, filling the nasal cavity, abutting the skull base, anterior skull base, causing the contour bulging, pushing the bone up. The clivus looks normal. There is a large cystic loculation in the nasopharynx. It is invading or moving the bone. It is kind of expansile kind of mass which is bulging into the anterior skull base.
What's your radiological diagnosis?
So as we can see that it is T2 bright and non-contrast enhancement is there and causing the contour bulging, not eroding. So my differential goes towards the either the slow growing, either the benign sinonasal tumor or slow growing malignant, low grade slow growing malignant tumor.
What's the biopsy?
Biopsy is poorly differentiated carcinoma.
That's quite an unusual looking to be a poorly differentiated carcinoma.
Yes, ma'am. Biopsy is differentiated carcinoma. Differentials they have given poorly differentiated is squamous cell carcinoma or nut midline carcinoma.
Okay. To me, anyways, I'm not a radiologist, but my first thing while looking at the scans was, is it an ameloblastoma with a typical soap bubble appearance?
Or an aneurysmal bone cyst. I could feel that there was, so that is definitely one differential where you can.
Yeah, so ABC, sorry, I meant a ABC, not a ameloblastoma. ABC is what I wanted to say.
So it looked very typically like this. What IHs they have done? I think you had a slide on histology report.
I will share, just give me a moment. Is my screen visible, sir?
Yeah.
Yes.
So ISC they have written as focal positive for cytokeratin, AMA, P40, P63, CD34 positive, S100 and synaptophysin positivity in occasional cells, negative for CD56, chromogranin, HMB45, SMA, CK5 or 6.
So what
Is my slide visible?
Yeah. So before this biopsy report, you said that on radiological, you feel it could be a benign or a low-grade malignancy.
Yes.
Now, on the radiology, you saw that there is a kind of an infiltration of the ITF as well.
Yes, sir.
So why do you thought, or what could be your probable diagnosis with all these findings with an ITF involvement? I mean, I've been just trying to ask you, what was your thought process of considering this as a benign?
So, because it is not there is a contour bulging of the bones. It is a big mass which is involving bilateral nasal cavity. It is abutting whole lamina, and only the contour bulging is there, expansile kind of thing. There is, in cases of high grade malignancy, we can see the erosion directly, not like the contour bulging as here I am seeing. So I thought it could be benign or low grade malignant tumor as first of my DD.
Okay. So when the biopsy was taken, was it very kind of vascular lesion?
It was bleeding, but it was not like that. Uh, it is not uncontrollable bleeding, yes, but it was vascular mass.
Okay, so what do you do next?
So if it is poorly differentiated squamous cell carcinoma or not midline carcinoma, I would like to counsel the patient regarding, if particularly if it is not midline carcinoma, I would like to counsel the patient regarding the prognosis and the aggressiveness of the disease. And
Is it better or worse than esthesioneuroblastoma?
it is worse. In all the series, on all the retrospective series, the maximum survival.
I was waiting for you to comment, but you never did, neither in your clinical evaluation nor here about the neck nodes. Was there any nodal disease?
No, sir, I have put, there was no lymphadenopathy.
In your MRI also there was nothing?
No, sir.
And what levels did you see?
Sir, specifically, I saw level 1B and level 2.
Not retropharyngeal?
Retropharyngeal, I could not appreciate actually.
On radiology?
Yeah, it is important to look for retropharyngeal lymph node, specifically when the mass is very part of the nasal cavity extending to the nasopharynx, involving posterior wall of the maxilla. Yes, we have to look for retropharyngeal.
And what is the relevance of PET scan?
So PET scan to see for the distant metastasis, as if it is an aggressive malignancy in cases of not midline carcinoma, the patient can present with the distant metastasis.
How do we treat him now?
So we have to use the multimodality treatment, a surgery followed by chemoradiotherapy, though we don't have the concrete data on that. But in all the series, they have used the all modalities of treatment in treating not midline carcinoma.
Kiran, there's
yes, please.
Sorry, Kiran, there's involvement of the infratemporal fossa and the widening of the pterygopalatine fossa, if I'm not mistaken, on the right side. You'll still operate this patient?
Because there is no perineural invasion, and the best cure we can give with this, with the surgery, so we can go ahead with the surgery.
What are the margins you expect with this surgery?
So I am not thinking I'm not thinking to get the very good margin, but because it is kind of expensive, we can do the total maxillectomy, and there is no perineural invasion. We can do the pterygopalatine fossa clearance along with infratemporal fossa clearance. And later on, we can subject the patient to.
I'm not wrong. Tumor was just abutting the medial maxillary wall on one side. It's not a pure maxillary tumor.
So on the left side, we can go ahead with we can do the medial maxillectomy, but on the right side, because it is involving the medial and posterior wall, so we have to do the total maxillectomy. Or we can, because patient age is 61-year-old and this nut midline carcinoma is very aggressive, we can give the option of radical CTRT to the patient.
Any role of neoadjuvant induction chemo?
Therapy in 61-year-old patient having nut midline carcinoma, there are not much reports on that. But in poorly differentiated squamous cell carcinoma, patient has given neoadjuvant chemotherapy in young patient.
Is there any other molecular marker you would want to do in this patient to tailor your treatment?
Yes, in nut midline carcinoma, for that we can do the translocation study, nut BRAT4, where we can see 15 to 19. If it shows positivity, definitely carcinoma, we can give the option of CT the patient. Considering
No, some other thing. So the nut carcinoma can be only confirmed only if you have the nut IHC or a translocation study positive. I'm asking with respect to planning therapy for the patient, would you want to do any other molecular markers for these patients?
with this histology, ma'am?
Yeah.
I'm not sure.
Is there any role of PDL1?
Yes, ma'am. We can look for immunotherapy. Recently, the article is there for Pembro in maxillary sinus carcinoma.
Okay. So leave aside nut and let's go back to the most common carcinoma. If this was a squamous cell carcinoma, would you still go ahead with total maxillectomy, ITF clearance, and then CTRT for the patient?
Because squamous cell carcinoma has perineural invasion tendency. So if it is high pterygopalatine fossa involvement, then we can go ahead with the radical CTRT.
How would you manage the neck when you're planning this patient? This patient has no nodes. Would you still address the neck?
So, there is controversy regarding the neck management. So there are two schools of thought. Some says if it is T3, T4 and high grade, we can do the selective neck dissection cases of N0. And the other school of thought says because it is T3, T4, T3, T4, you are subject after the surgery with the adjuvant radiation. So the neck will be irradiated at the that. So there is.
Would you address, if you're surgically treating the neck, would you address the nodes of Rouvier?
Nodes of Rouvier we can address with the adjuvant radiation.
Okay. What if this patient had an adenocarcinoma? How would your management change for this patient?
So for adenocarcinoma, there is a paper by Lisa Lesetra and Bossi et al. In 2013, I guess, where they have used PFL resin, cisplatin 5-fluorouracil and leucovorin in cases of P53 wild type. So in intestinal type of adenocarcinoma, they have checked the IHC P53. If it is wild kind of P53, then they have given this PFL resin and they have seen the overall survival advantage.
I'm sorry to interrupt. Kiran, whenever you start answering something, please do not start answering by the evidence. First, tell the concept that you are telling in. If required, then you please give the evidence.
Okay, sir. Sorry, sir.
I believe that is okay, Deepa ma'am.
I agree with you, Asim. First, you tell your plan and then you can back it up with evidence.
Yeah, please continue, please.
So in adenocarcinoma, first we have to check whether it is intestinal or non-intestinal. So if it is intestinal type of adenocarcinoma, then there is a role of neoadjuvant chemotherapy when it is abutting lamina or involving ITF. We can go ahead with the or involving the dura. Then we can go ahead with the NACT. With PFL regime, cisplatin, 5-fluorouracil, leucovorin, and then after NACT we can do the surgery.
So we are getting well past 7. Yeah, yes. Sorry.
Or non-intestinal.
Sorry, ma'am. Hello. Am I audible?
So in patients for adenocarcinoma.
Sorry, ma'am. Could you tell again? I couldn't get you. Hello. Am I audible?
Yes, you are audible.
You are audible. I think we have lost Deepa ma'am. Just wait a minute. Wait for a moment.
So if we plan to operate this case, can it be pure
Sorry.
endoscopy? If Dr. Deepa has joined back. If not, then can you
Go
answer?
ahead, Kapil. I have some.
Yes. Can it be pure endoscopic?
Sir, because it is involving infratemporal fossa, involving pterygopalatine fossa, medial wall, and posterolateral wall. So better to do the total maxillectomy. Then we can get.
So total maxillectomy, you are putting is an indication for accessing infratemporal fossa.
So because it is involving not as an indication, but yes, for good clearance of infratemporal fossa, and as it is involving the two walls of the maxilla, I might prefer total maxillectomy, open total maxillectomy instead of endoscopy.
So you'll remove the palate and alveolus, which is seemingly uninvolved?
Keeping the palate intact and removing the infratemporal fossa, I won't get my margin because it is involving the posterior.
What margin are you looking at?
So I am looking for the palatine, greater palatine margin. I'm not sure for that. So I may not proceed with the endoscopic for that region.
So you are saying one side total maxillectomy, other side medial maxillectomy, both side infratemporal clearance?
Or not both sides, sir. Only the right side infratemporal fossa.
The right side ITF clearance.
Yes.
And how do you plan to reconstruct the defect?
Because the orbital plate will go, so I would like to reconstruct with free fibula flap.
Do you expect a dural defect?
Yes, sir. There could be dural defect.
Why do you think there will be dural defect?
Because, sir, it is abutting the anterior skull base, so I would like to remove the bony bones, and I would like to check my margin on the dura. I'm not sure what will be my frozen report. I would like to send the frozen from the superior part of the nasal cavity, from the dura.
Will your management change if you encounter a CSF leak?
So if I found intraop CSF leak, I would like to give good repair on the anterior skull base. Maybe I would like prefer soft tissue flap or yes, soft tissue flap.
And
with a reconstruction of dura with the pericranium.
With
Sorry,
pericranium. So you'll stick with your free fibula and you'll put a pericranium for dura.
Sir, if orbital floor has gone, then for good cosmesis, I would like to put free fibula if the patient is young. for good
internet issues and traveling. So old patients don't deserve cosmesis. Is cosmesis the only indication to put in fibula for the patient?
comorbidity also, if the patient is high risk for long GFS.
What is your aim of orbital flow reconstruction?
So to prevent the sunking of the orbit, to give the rigid support to the floor of the orbit.
How will you achieve that, and what are your endpoints in achieving optimal orbital flow reconstruction? You are doing a bit of reconstructive surgery now in Amrita, aren't you? So as a surgeon, what are the precautions you will take during surgery to achieve optimal orbital flow reconstruction?
So, if possible, I would like to keep my periorbita intact. If it is not possible, then I would like to reconstruct the floor of the orbit by bow, or if patient is not fit for free fibula by saying having the comorbidity, then we can go, and patient requires bulk, muscle bulk, then I would do the plating for the inferior orbital floor, and will put soft tissue flap.
Where will you anchor the plates if you are doing plating?
So the plates we can anchor on the lateral wall of the orbit, and on laterally, and lateral wall of orbit and zygoma laterally, and medially on the nasal bone.
So basically, you want to reconstruct the orbit so that the patient has adequate support of the orbit, so that the patient does not develop in ophthalmos or change in the level of the orbit to prevent a diplopia of patients. Okay. So if you are going to resect the periorbita, the first thing is to sort of give a orbital sling, and then have an adequate rigid reconstruction so that your level of the orbit is maintained on both sides, so that there's no inophthalmos as well as no shift in the axis of the globe. Okay, so when you are talking about goals of orbital reconstruction, you have to think about all of these points. It's not just about I'll do a fibula or I will do a rigid plate. Always think about what is your goal of reconstruction. Okay, Asim, do we have any more time, or you want us to wrap up now?
I think maybe we can wrap up in next 1 or 2 minutes. I would ask you to give the end comments and Dr. Kapil to give the end comments.
Let Kapil start, please. I know Kiran very closely, so I think we should ask for Kapil's evaluation.
I've also started knowing her. It was a good case selection, I would say. You presented it well. There were some lacunae in your history and clinical examination which are acceptable, but I feel that you should improve on that. I would have liked to have a CT and photography if you are presenting to an audience which are foreign to your institute. I would have liked to see the clinical photographs, the pictures, and also radiology that was lacking. Your knowledge of subject was good. And your concepts were well developed. You had basic skills to present that, and your knowledge was good. So I would suggest you keep it up.
So I think Kiran did a good job. Like I echo exactly what Kapil says. And it's not surprising because Kiran has worked with us as a skull-based fellow. She has worked exclusively in these tumors for a year. But well done, Kiran. Like Kapil said, just keep working on your presentation slightly more and make it more concise so that you can directly reach the management, avoiding too much delay at the present history and examination findings. But well done overall. All the best.
Thank you so much, ma'am. I just call Ravi for the final end note and the Thanksgiving. Thank you so much.
Thank you, Dr. Asim. I would like to thank all the faculties, especially Deepa ma'am, Kapil sir, Dr. Rahul Naga, Pankhuri ma'am, and Dr. Siddharth Shah sir, for taking their time out for this case discussion today. And very special thanks to Dr. Kiran Joshi for such a nice and great presentation. It was really very academic presentation for all of us. It really benefited us a lot. Thank you so much, Dr. Kiran. Thank you, everybody.
Thank you.
Thank you. Bye, everyone.